and Zoom is a wonderful tool. It makes meetings and events more and less intimate at the same time. We have a lot longer to adapt to virtual. We've had a lot longer to adapt to virtual meetings at this point. And Zoom just lets people from all over join in seamlessly. So it's really great. You know, one of our panelists lives in Massachusetts, and another one's from Western North Carolina, and we're all from different places. So this is really lovely. Many people have been meeting and consulting on this event, and I want to thank Gerrie Richards and Virginia Carson and Kathy Rausch and Vicki DeGroat and Annie Clark and Maisie Rising and Penny DePaul and lots of Chapel Hill Now people I don't probably even know, and Jennifer Albright and everybody, and Esther Barkley from Durham Now for working on this and helping to get the name out and everything, the word out. And I also want to thank Vicki for volunteering to run the Zoom. So yesterday, NC Now published its pro-choice signature ad. We've been doing this for decades, but we're designing them differently now. And so make sure to grab a copy of the Indy if you're anywhere in or near the Triangle, and look at the centerfold, and you should see us and our names and a statement, and also some quotes from the U.S. Solicitor General, Elizabeth Prelogar, who is a young, brilliant lawyer who's arguing the Supreme Court cases for us. And we have a great program today. Let's see. The program is here. Let me get this for you. So we have a program that was snazzed up in Canva by Maisie Rising. So it looks really great. We're really excited about it. So we've got the agenda in here and the biographies and ways to contact NC Now. So that's basically what we have there. But it's colorful and snazzy. And we are honored to have all of you join us, but want to call out a couple people in particular. We have Senator Valerie Fouché, who is running for Congress, and yay, and Senator Natalie Murdoch, yay, and I believe Lisa Grafstein, you're running for something, right? Lisa Grafstein's here.
Yes, thank you. I'm running for the North Carolina House. I'm sorry, I'm in the car. That's why I don't have my video on.
No, that's exciting, because we need more women in office, more progressive women, progressive people, but also progressive women in office. And am I missing anybody? I know Representative Verla Insko was signed up to come and will be here at some point. And she's been amazing. I don't know how you guys in the legislature can put up with all the stuff that you put up with. She got to deal with all the time, and we so appreciate you. So you can look at your agenda and your program, and if you have questions or anything, put them in the chat. We'll be monitoring the chat, and we hope that you learn more about Roe and what's going on now and what might happen and what we can do about it. And if you're not already a member, there's a membership form on the last page of the program, because NOW is a grassroots organization, and we'd love to include you, your interests and abilities, and your dreams for a better future for all women. So Next, we have Gerrie Richards, who's the president of Chapel Hill Now, and who has something special for us. And she's going to be the moderator of the panel.
Okay. I don't see Audrey here, Gailya.
Okay. If she
So I'm
comes
gonna-
later, we'll grab her.
Okay, if we can get her in there, yes. Hi, everyone. Thank you all for being here tonight. I appreciate your support, and I appreciate your being here. And a shout out to the Chapel Hill Now members who are part of this team and who are in the audience right now. On December 26th of 2021, Sarah Weddington died. Reading the New York Times obituary was really my first introduction to this woman who was so significant in my life and the lives of all women in the United States. Now, that's an embarrassing thing to admit for a person in my position. But on the other hand, that was my motivation, or the motivation that led me to find out more about her. As I did, it became evident that her life and mine and the lives of many who are listening to this right now share some themes. I'm going to give you the themes, here they are, and let's see what you think. Can you relate to any of these themes? The first theme is this: come of age in a time of change, and then become the rebel in the family. Sarah came from a traditionally religious family, but in her third year of law school at the University of Texas, she became pregnant with Ron Weddington, her future husband. This might have derailed her life, but they traveled from Texas to Mexico, where she had a safe abortion. Theme number 2, fake it until you make it. And sometimes fate leads the way. In 1967, Sarah graduated from the University of Texas Law School, only 1 out of 5 women in her class. She couldn't find a job in law or one that she liked, so she joined a group of University of Texas graduate students researching ways to challenge various anti-abortion statutes. A group of women in Texas who had been referring other women to US doctors who would perform an illegal abortion, or to countries where they could get a legal abortion, contacted Sarah in this group to ask if they could be prosecuted as accomplices. I wonder if that doesn't sound familiar. As part of her research, Sarah contacted Linda Coffey, who at the time had a client named Norma McCovey, who had tried unsuccessfully to obtain an abortion. We know Norma McCovey as Jane Roe. As a result of this connection, Linda Coffey invited Sarah to work with her. Among other reasons, Linda told Sarah that she thought it would be more fun to work together. And isn't that our experience? Theme number 3, use the weapons that you have at your disposal. By all accounts, Linda Coffey was brilliant, but she was not good at being on the public stage. She later said this: Sarah was young, blonde, blue-eyed, and enjoyed the public stage of a courtroom. Even though she had never tried a legal case, at 26, Sarah argued this case before the Supreme Court for the first time. Theme number 4, be bold. And sometimes it's who you know. By 1973, Sarah was already moving on to the next stage of her career, serving in the Texas legislature. Ann Richards, no relation to me, unfortunately, the future governor of Texas, and Cecile Richards' mother, was one of Sarah's legislative aides. Ann helped draft 2 important pieces of legislation for which Sarah received credit. One increased the statute of limitations on rape cases, and the other barred questioning a rape victim about prior sex life. Theme number 5, nobody's perfect. It seems that Sarah knew another Southerner, Jimmy Carter. In 1977, while working for the Department of Agriculture, she was invited by Carter to take the position of assistant to the president. Now, Carter was anti-abortion. It seems that Sarah made some statements that did not sit well with pro-abortion advocates. Now, however, in 1978, she may just have made up for this by masterminding the Senate's approval of extending the deadline for the ERA. Theme number 6, pass it on. At the end of the Carter administration, Sarah published A Matter of Choice, her firsthand account of her life in the Roe case. She also founded the Weddington Center to encourage women into higher leadership positions and everyone to become involved in public and volunteer leadership. Until 2012, Sarah was a lecturer and adjunct professor at the University of Texas, Austin. Theme number 7, progress is not linear. Consider now these 2 quotes. The first one comes from the New York Times obituary. Polls show that Americans are more familiar with Roe than with almost any other Supreme Court decision. Now, the second quote is from Sarah herself. Now, Sarah died shortly after the Supreme Court heard oral arguments in the Dobbs versus Jackson Women's Health Organization. So this quote is not recent, but I think it is significant for us to consider tonight. She said this: I thought that the right of a woman to make a decision about what she would do in a particular pregnancy would be accepted, that the controversy over abortion would have gradually faded away like the closing scenes of a movie, and we could go on to other issues. I was wrong. So here we are today, here we are tonight, just past the 49th anniversary of Roe and talking about abortion and reproductive rights. I can't help but feel that we are asked by Sarah Weddington to be bold, to use the weapons that we have, and to continue to strive for justice. Thank you, Sarah Weddington, for all you did and for who you were. Okay, now let's move on to the next part of our evening here, the panel presentations. Let me just remind you of how this is going to happen. Each panelist will have a certain amount of time, maybe from 5 to 10 minutes to speak. During these presentations, please keep yourself muted. But at any time during the presentation or during the discussion, any member of the audience may put a question to a particular panelist or for the group of panelists into the chat. I encourage you to use this option, so please take advantage of it. After the last panelist has finished speaking, Virginia Carson will moderate the Q&A portion of tonight's event. Virginia will direct questions either to an individual or to the group of panelists. So she's going to manage that part of the whole event. All right, so let's get started. Let me introduce our first speaker. I want to say one more thing before I go. I've cut down the biographies, but please take a look at the agenda and at the program for this meeting. There's much more about these individuals that you might be interested in seeing. But our first speaker tonight is Dr. Pettigrew. Dr. Pettigrew is a family medicine physician in Hillsborough and Chapel Hill. She completed her medical and law school degrees at the University of North Carolina, right here in Chapel Hill. She also has a master's in public health, and she's a professor at UNC School of Medicine. Her focus is on her practice and how human rights can connect, how she can foment or promote human rights through medicine. And she uses this sense of reproductive justice as a lens for the work that she does. Thank you, Dr. Pettigrew, for being here this evening. Please unmute yourself, and we're anxious to hear what you have to say.
Sure. Thank you, Gerrie. I appreciate that. And thank you for everybody joining this event on an evening, giving up your evening for this. I actually just wanted to share, before I started talking about medicine and being a abortion provider, I actually wanted to share my own Sarah Weddington story. So when I was an undergrad at the University of Georgia, I got to hear her speak, and I fangirled her so much. I brought my, so I was that nerdy undergrad that had a constitutional law book from one of my classes. And I actually got her to sign my my Roe v. Wade page. I don't know if y'all can, oh wait, how do I do that? There we go. So it just says "Cheers for Choice, Sarah Weddington." And so
Oh, cool.
get to keep that forever. I love that I got to meet her. And the fact that she was 26 when she argued Roe in front of the Supreme Court is amazing, and also sometimes makes me wonder what I'm doing with my life. But she's just an incredible, incredible woman. So in a way, and this is maybe a weird thing to say, but you know, we know that Roe is in major trouble, and we'll see what the final outcome is, but it's not going to be good. And I'm kind of glad she won't have to see that. Yeah. But I wanted to just take a few minutes. I know that this is going to be a pretty heavy night. There's a lot of trepidation about what's going to happen at the Supreme Court level, and then what's going to happen in North Carolina, especially with the upcoming elections and the gerrymandering that went on, and whether we end up with another supermajority. So I just wanted to start by talking about how wonderful it is to be a family doc and an abortion provider, and just sort of share that perspective for a couple of minutes. As Gerrie mentioned, I'm a family doc. I'm not an OBGYN. You don't have to be an OBGYN to be an abortion provider. Family medicine, we deliver babies, we do geriatrics, we do everything. We take care of kids. And reproductive health care is such an important part of the care that we deliver. It's an important part of my practice. I work at the Orange County Health Department. I also work at UNC. I will say, in the interest of full disclosure, I unfortunately have not been able to provide abortions during COVID because my other jobs sort of took over, and I had to put that moonlighting aside temporarily. But it's a really rewarding part of my life and my career. I think that sometimes people may see it as a sacrifice in some way, but it is one of the few places in medicine where you can so dramatically change somebody's life in 5 minutes. And I just find it really rewarding to be a part of somebody's journey, and they trust me and my clinic crew to deliver that care. And so it's so frustrating, the obstacles that politicians and courts put into place that really don't add anything to the medical experience and just add barriers to people getting the care that they need. Here in North Carolina, we have a multitude of those regulations, and I know Dr. Nimalendran is also going to speak to her experience with them, but we have things, for instance, somebody who has made an appointment at a clinic has to have a state script read to them by a certain type of clinician that is not medically accurate. And then they have to wait 72 hours before they're allowed to have the abortion that they had already decided was in their best interest. And that is just so incredibly paternalistic. And so it's things like that, it doesn't have to be that way. It's gotten a lot worse in North Carolina in the last 10 years. North Carolina was actually a pretty good place to practice until about 2012, 2013. And then we've had some pretty egregious bills put into place. And so I think I'll close by just sharing that, one of the other experiences that I often have working on a Saturday in an abortion clinic is that the patients tend to be so incredibly grateful. And it's really heartbreaking because they often will say in the recovery room or immediately afterwards, I've had so many people say, "You were just so nice. Thank you." And they're sometimes crying. They're just so relieved. And it's clear that they expected to be treated like a monster. They had been treated like they didn't have the ability to make this decision leading up to it. They had to jump through all kinds of hoops. They may have had interactions with protesters outside of the clinic who were screaming at them as they were walking in, and they don't know what to expect. And sometimes their own family and friends are telling them that what they're doing is wrong. And so sometimes people internalize that. And it's just absolutely heartbreaking because all I'm doing is my job and providing the care that they need in that moment and doing it with compassion, which I do every day with adjusting high blood pressure medication and diabetes and everything else. And yet I don't have my diabetic patients with tears in their eyes at the end of my clinic visits, thanking me profusely for adjusting their insulin. And so I think that that's something that we just need to figure out how to move forward and how to really keep the patients at the center and really continue to work. I mean, it's exhausting, but all the activists work in pushing back against these egregious laws and hopefully one day coming up with laws that actually put protections in place and help promote people's autonomy in making these decisions. The fight will continue, but I'm just very grateful that y'all are there and fighting the good fight. So I'll conclude my introduction there and happy to answer questions at the end. Thank you.
Thank you, Dr. Pettigrew. It's interesting, yes, to hear and to think of this from the patient's point of view. So we appreciate your sharing. Our next speaker is Dr. Nimalendran. And she is also a family medicine physician, and she is in Western North Carolina. She has some experience and interest in rural community health here in Chapel Hill, where we're so urban. That's a new angle for us. She is also an abortion provider, and she's been doing that for 2.5 years now. Among the things that she does in her spare time, which I appreciate and like, is that she enjoys railing against inequality to anyone who will listen. So we will listen to you. You don't have to rail. We get the point. We understand that very much, but we're very glad to have you here tonight. So please share what you have with us.
Thank you so much for having me. First, I want to just say, thank you to all those, including, Sarah Weddington, et cetera, and all of you here who have been working to make it possible for me to be an abortion provider. I also want to just say I'm super excited because I voted for Senator Murdoch when I lived in Durham, and I'm like fangirling out here. And a little bit about what brought me to abortion work, like Dr. Pettigrew, who is one of my mentors, and helped me actually be able to practice, which is no easy feat. I actually decided I wanted, if I became a doctor, because I was a South Asian kid with South Asian parents, that was like the only option. I wanted to provide abortions at the age of about 12 or 13. And I remember I had a very progressive mother, and pretty early on, my family's from Sri Lanka. where abortion is illegal, I learned that my mom's cousin, who was about 19, she was a massage therapist in the 1950s, not, for their respectable family, not so great. And my mom remembers waking up one morning and all the adults were gathered around because her cousin had died from a septic botched abortion, illegal abortion. And my grandmother told my 5-year-old, at the time, 5-year-old uncle and cousin, when they asked what happened to cousin, well, she ate too much sugar and she got a stomach ache and died. So they took that to heart. But that was kind of my first experience. And then my mom telling me about her experience as a college student, helping a friend, get a pregnancy test who was impregnated by a professor who was inappropriately having an affair with her, who then had to get an abortion. My aunt telling me about her abortion, and various family members telling me about their having to obtain illegal abortions in Sri Lanka. So that really paved the way for me to want to become a provider. I never felt that a person shouldn't have the option to choose. It just didn't make sense. But over the last 20 years, between going to Wellesley College, which is very, very progressive, and just over the last few years, I've really kind of grown in what I believe of kind of really wanting to model that reproductive justice in my work and in how I provide my work. So I trained in medical school at Columbia in New York, where, as I said, you can get abortion easier than you can get a big gulp. And it was so nice. There were no protesters. The patients just came on the subway to like this high-rise building on a Saturday and their Medicaid paid for it, right? And then I came down to North Carolina, where I was very clear that I wanted to be an abortion provider, not realizing, that might be a controversial statement. And luckily I was really supported at UNC by people like Erica to get that training and make clear my interests. So I did extra training in a 4th year, which allowed me at Planned Parenthood, and have provided for Planned Parenthood the last 2.5 years at several of their sites. Like Erica said, it's one of the, during my day-to-day job, I'm getting not as much as Erica, but Dr. Pettigrew, but I'm getting blasted by COVID. I'm seeing patients, I'm pregnant, I'm seeing patients outside in 30-degree weather in their cars for COVID. And it's grating. It's really grating when I'm like, just get vaccinated. What am I doing out here? But when I go to Planned Parenthood, even though it's terrifying, even though there are tons of protesters, and one of them, who's like a 30-year-old man who looks like he might have been at the Capitol riots, knows my name and yells at me and videotapes me as I'm getting out of the car. And my heart rate is about 150. I walk in, and again, the patients, when they walk in to see me, they're scared, they're worried, but they also feel like they've been in good hands because everyone they've met before me, from the ultrasound tech to the person at the front door to the escort, has treated them with kindness. And when they get to me and they realize that that's just going to continue, and if it's a medication abortion, it's 5 minutes and then I'm going to get you out of there, or if it's a procedure, we're going to be holding your hand and supporting you in whatever way you need. I had a patient say, watching people walk out, go in to see you, and then walking out, the relief was palpable. Some were laughing, some were just so relieved. And that's what makes it worth it. That's what makes it so important, that I'm like, ridiculous man on a ladder screaming at us with a terrible poster. You don't understand. You don't see the humanity in what we do. So I think that's one part that I think is really important, just like Dr. Pettigrew said. Again, there's so many restrictions and so much stigma, just both socially and politically, and hoops people have to jump through. I often find that I ask a patient, if you're getting birth control from your GYN, are you comfortable telling them that you had an abortion, because your pregnancy test might still be positive? And I teach people the wording to essentially lie. Like, this is the same medication we use for a miscarriage. You had a miscarriage. There is no reason you have to tell anyone ever that you had an abortion if that's not right for you. no doctor at the hospital is going to know. You can, there's not a way for them to look at that in your blood. But it's sad when I have to send someone home with the medication and they have no one to support them. And they're trying to hide it from their mother. I'm helping them put the pills in their wallet so their mom won't see it. And that part is really devastating. I think the second part that I still am working, that I think we still need to improve also, is the aspect of racial inequality and gender inequality in reproductive health and abortion care and how we treat women. When I started this work, I was very much like, all right, you're getting abortion. What's your birth control? And now, I realize that's just not that's not the best way. It's a very kind of white patriarchal manner of operating. So trying to see where patients are and what I can do to best support them. And that might mean they're seeing me again in 8 weeks for another abortion, but that was not, I give them the information and I try to help guide them. But I think the really important thing in this work is that we allow people to make the choices that are right for them. That might be someone is in my room and we're about to take the pill and they start sobbing and we start talking and we decide she's not going to have that abortion. And that's also wonderful. That's okay. And so I think that's my favorite part about the choice, and being able to hold that moment for that person's life and try to make it so it's not as scary and it's not as not a bad experience. I know there's times when I really struggle. My other part is we don't have Medicaid, doesn't pay for it. I had a patient who was raped. She had to go back home to her 1-year-old baby, so she couldn't get even an Ativan for sedation. And she wanted to use her Medicaid, like the person was in jail, but they were making it so difficult and re-triggering her by asking her to bring all this paperwork. And she's like, I'm just going to pay for it. I can't go through this again. And all of these are huge obstacles to patients. It's almost $400 to $500 starting out to get an abortion. Most people just don't have that money. And so it gets later and later and the abortion gets harder and harder. Sorry, I can talk about this forever. So I will stop now. And just, happy to take any questions about the hoops patients and providers have to jump through.
Mhm. Thank you so much for sharing the personal stories of your family and friends, but also your personal perspective on working with patients who are having abortions. I truly believe it is these stories that make a difference in helping everyone to understand what's going on. Thank you again. Our next speaker is, and she's not a doctor, I almost said doctor, Gailya Paliga. Gailya is, as you now know, is the president of North Carolina NOW and also of Raleigh NOW. She is key to organizing many events like this and works, I'll tell you, those who know her know she works tirelessly, especially when you wake up in the morning and you find that she sent you an email or a message at 2 or 3 o'clock in the morning. There's no denying that she puts everything into this work. So Gailya, we're looking forward to having the information that you have about this procedure and what's going on in North Carolina. Thank you.
Thanks, Gerrie. Thanks for that. Yeah, sometimes 4 or 5 in the morning. Hi, everybody. Okay, so you know who I am, and I'm here to talk about the laws in the state and what we might expect. Now members tend to want to be the ones that take action. And also NC NOW tracks legislation in the state that affects women, historically providing weekly reports during active legislation sessions. Robin Davis has been doing that for many years. Before that, Paula Wolf, and before that, Ann Winter. And so Robin keeps us up to date on what's going on, which is amazing. And then also NC NOW has a political action committee. And so we make endorsements because, who's in office is so important. And that'll be a round of that'll be coming up soon. So look for your yellow cards in front of the general elections. But anyway, also, well, anyway, so what we have now, North Carolina is considered hostile to abortion, and I would say hostile to women. This classification is from the Guttmacher Institute, which is a leading sexual and reproductive health research and policy organization. They've been around a long time. We did not used to be hostile to abortion, actually, unusually so, maybe in the South, but we were pretty reasonable before 2011. There was just the parental restrictions where younger women, girls would have to get parental permission, which sometimes your parents will kill you. It's not a great thing, but that was really most of what we had then. And now we have all these extraneous restrictions. The number of people ask about the number of clinics. They're currently around 14, but also abortions are provided in hospitals and other facilities. So according to Guttmacher, there's 26 total facilities providing abortion now. And this is 13% fewer than there were in 2014. There were 37 in 2014, and 16 of those were clinics. Now there's 14. And the clinics tend to be in big cities. And so basically 91% of counties don't have abortion clinics. And 53% of North Carolina women live in those counties that don't have clinics. And this year, it's the legislature, the budget was so bad. I know it wasn't supposed to be bad, and there are some okay things in it. There are like small raises for teachers, but oh my God, they gave $15.8 million to crisis pregnancy centers and umbrella organizations. Almost $16 million of taxpayer money to these organizations that have religious ties and actively work. Basically, their reason for existing is to talk women out of abortions. That's why they exist. They don't, like Susan Hill's clinic used to provide abortions and other medical care. They do not do this. So it's outrageous for taxpayer money to be going these places. And this is a huge, unbelievable increase. This is so outrageous. Like before 2013, we didn't give money away to CPCs. And in 2013, it was $300,000, which was outrageous. And the last time we had a budget go through in 2017, it was like $1.55 million. And the next proposal was $2.6 million, but it didn't go through. And this year, the Senate and the House both had in their budget passes a lot of $1 million, but less than this. Almost $16 is just ridiculous and disgusting. And you guys know Professor Gene Nichols from UNC, who's a constitutional law professor. He did an op-ed last year saying it's unconstitutional to do this. So that is happening. And then there's all of these restrictions and changes in law since 2011 to interfere with women getting abortions and to make it tough and sometimes dangerous for doctors. Like Dr. Nimalendran talked about the 72-hour waiting period and the forced ultrasounds and the card that's with incorrect information on it. They're forcing people to read, although I thought there was a change. There might have been a change to that one. And now women's ultrasounds of their abortions, if they get an abortion after 16 weeks, are sent to the state, to the Department of Health and Human Services to have to save and for someone to go through later. So right now we have just had the beloved and well-respected Mandy Cohen in charge of DHHS, thank goodness. Before her, the lady was not good. And after her, if people don't get out and vote, who knows who's gonna be there. So seriously, the records are there, the doctors' names are there. It's not good. And you know, all of this stuff is being done regardless of how safe abortion is, because abortion is super safe. And what is it, like 14 times more safe than having a baby? And so that's that. Now, there are anti-abortion bills that were filed again this year, even though the majority of North Carolinians support safe and legal abortion. And one of the first one was a 6-week abortion ban, which they call a heartbeat bill, even though there's no heart. It's 6 weeks of gestation is really only 4 weeks of pregnancy, and there's no heart there, not for another 2 months. So these bills are terrible, and they're named so that they are misleading. And there's tons of other problems with 6-week abortion bans. But this one also imposed criminal sanctions on abortion providers who are already beleaguered, as you heard. So that was one bill here. Another bill that was filed here was for fetal personhood. And fetal personhood is a concept there that persons are protected in the US Constitution in the 5th and 14th Amendment from government, state or federal action. And so at least one state lawmaker wanted to redefine cells to be a person, which would completely stop abortion, but it's also incorrect. So it's very drastic, and that's come up and could come up again. I mean, we were having events on fetal personhood in 2008 and 2009, but it was much less likely to be pushed through at that time, let's just say. I have a list of restrictions on abortion that I'm not going to go through. You can look them up on Guttmacher's, but we mentioned some of them. Abortions covered in insurance policies for only in the cases of life, endangerment, rape, and incest for the state, for some insurance policies for public employees. And you heard about the ultrasound, all that stuff. Okay, that's done. So I'm skipping those. If we would lose Roe, God forbid, then right now, the federal protection of women's abortion rights will go away, and everything will depend on state law. So right now, we would still have access to abortion, but over time, our situation could become progressively worse, because without the federal protection of Roe, legislators will not be hindered from implementing changes that were previously banned by Roe. And if we keep the same legislative makeup we have now and the same leadership we have now, the sky's the limit on bad legislation. They've shown that they don't value women. They value corporations over people and untested religious theory over scientific research. And they're already proposed and even passed bad bills that, thank goodness, you know, since we've had Governor Cooper has vetoed a ton of bad bills, with his party standing together behind him. But you know, there's been a lot of work to try to break that up, and like I said, the state budget's not good. the legislative leadership has also shown that they'll follow the lead of other states. For example, when abortion bans swept the country in 2019, we had them too. So, and that 6-week ban. So NC is kind of the perfect example of out of control gerrymandering's worst effects. So this is, again, why it's so important to vote, and vote all the way down the ticket. We cannot afford ballot fall off, and like, vote for your judges. And you can make sure to get informed about our judicial races and vote for the judges who will not implement the anti-abortion agenda. Use our endorsements, statewide endorsements. Also, make sure to tell your representatives at all levels that you support safe and legal and just access for abortion and safety considerations for abortion doctors and staff. And that's all for now. Thank you for listening.
Okay, thank you, Gailya. All right. Our next speaker is Professor Carrie Baker. And I'm just going to say one or two things. She is both a doctor of philosophy. She's a professor at Smith College in the program for the study of women and gender. And she is also a lawyer with an expertise in women's rights, law, and policy. You may, if you get Ms. Magazine, I'm sure you have seen articles written by Dr. Baker. And so we're especially pleased to have her with us again this evening. She was with us last year, so it's great to see her again this evening. And I'll just let you get started. Thank you, Dr. Baker.
Great, so nice to be here. Wonderful to see everybody. So I've been asked tonight to speak to what can the federal government do to maintain the rights guaranteed to women by Roe if the Supreme Court weakens Roe, and what is constitutionally possible if Roe is gutted by the Supreme Court. So just briefly, I think that it's highly likely that the Supreme Court is going to gut or entirely eliminate Roe. And I hate to be negative. I'm usually a pretty positive person, but if you attended the oral arguments on December 1st, it was pretty clear that definitely 5 members of the court, at least, were very willing not only to uphold the Mississippi 15-week abortion ban, but to go farther to absolutely get rid of Roe. I think that Chief Justice Roberts maybe is more moderate, meaning that he would just, and I say just in quotes, uphold the Mississippi law. But I think that Roe is not long, unfortunately, for this world. And, you know, I think that's the consensus of observers, legal observers and others. So I think we need to be preparing for a post-Roe world and what that means for abortion access and women's health in this country. You know, maybe I'm wrong and they won't do it, but I think it's highly likely that they will. So the question, you know, being what is constitutionally possible if Roe is gutted by the Supreme Court? I mean, Roe is a floor created by the Constitution. If Roe is gone, there's no floor, and it falls back to the states, and the states can restrict abortion. That said, there are things that the federal government could do to try to strengthen abortion rights if it, you know, got itself together. You know, with the current Senate, nothing's going to happen as far as abortion rights, but the House has passed a few measures that, if we could get through the Senate, would be incredibly helpful. And the first one I want to talk about is the Women's Health Protection Act. And I've dropped in the chat my Ms. Magazine article about this law. What the Women's Health Protection Act would do is it would establish a federal statutory right for providers to deliver and for patients to receive abortion care free from medically unnecessary bans and restrictions. So not only would it do what Roe does, which, you know, guarantee abortion rights, it could potentially get rid of things like your waiting period and other unnecessary restrictions, of which there are many, many, many throughout the country. The bill explicitly protects against many of the most common and burdensome restrictions favored by the anti-abortion lawmakers, and would protect the right to abortion nationwide, including in North Carolina. So that would be huge. It has passed the House, but it's being filibustered in the Senate. So, potentially that could happen, but it's a heavy lift. The other piece of federal legislation that's really significant and could also help a lot of people with regard to abortion health care is what's called the Each Woman Act. And I'm dropping this also in the box. The Each Woman Act would ensure that people can obtain insurance coverage of abortion, whether they get coverage or care through Medicaid, Medicare, other public programs, or private health programs. So many states not only, let me back up. So the federal Medicaid program only covers abortion in very, very narrow circumstances. Basically, if your life is in danger or in cases of rape or incest. And basically those last two are imaginary because it's the burdens to prove are so high. Just like was mentioned earlier, it's basically not in coverage at all. The Hyde Amendment is, that's because of something called the Hyde Amendment, which prohibits any federal money from going towards abortion. It also prevents federal workers from gaining abortion coverage, people living on reservations, Native Americans through the Indian Health Service, people working for, Peace Corps, the military, anything. It bans any sort of federal funding. What the Each Woman Act would do is get rid of the Hyde Amendment, and it would require, and require coverage of abortion through public insurance, but more also, really importantly, through private insurance, because many states ban private insurance from covering abortion, and many private insurance companies don't cover abortion. So this would basically, significantly expand abortion healthcare access. And remember that 75% of people getting abortion in the United States are low income. So this is a huge barrier to abortion healthcare. We have all these wonderful abortion funds, over, I think, 80 or 90 across the country, that raise money and help people. But, it shouldn't be that way. It shouldn't be that way. It should be part of our, North Carolina bans any private insurance sold on the ACA marketplace from covering abortion. So the Each Act would reverse that, would prohibit that kind of law. Now, I think it could pass the House. It has not yet passed the House. I think it's highly unlikely to pass the Senate. But that is a piece of federal legislation that, if could pass, would be amazing and wonderful and shore up abortion rights. Yeah, somebody dropped the Carolina Abortion Fund is your local fund, but they never have enough money. So write a check to the Carolina Abortion Fund if you can. And it says, as well as ban state health plan from covering abortion care for state public employees. So yeah, you're kind of in the worst of situations. So another example that currently abortion is legal but not accessible, another comment in the box. So thank you. So, those are two pieces of congressional legislation. Another thing is, so the Hyde Amendment passes every year as a budget amendment, and it's always been just in the president's budget as a matter of course, Democrats and Republicans. Biden, for the first time, submitted a budget without the Hyde Amendment, which is a huge damn deal, because for years, Biden supported the Hyde Amendment, but it was reproductive justice movement activism that persuaded Biden to drop his support of the Hyde Amendment, which is wonderful. We'll see what happens to that budget, but that is another approach. It's more, it's a little less direct. It's not as permanent as the Each Woman Act, but it's, it would still be great. There wouldn't be a Hyde Amendment. That would really open things up. So those are three things. Another thing, and this is a little removed directly from abortion, but is tremendously important for healthcare, is the federal government should expand the Title X program. Title X provides reproductive health care to low-income people, people that don't qualify for Medicaid, but don't have their own private health insurance programs or access to other kinds of health insurance. It's a critically important program that provides contraceptive care, cancer screenings, STD testing for low-income people. That program has been perpetually underfunded for ever since it was passed by, ironically signed by Nixon in 1970. And Biden put a lot more money into it when he got into office. Of course, Trump gutted it by prohibiting anybody who refers people for abortion care for using that money. And that cut out like Planned Parenthood, for instance. But Biden immediately reversed that Trump policy. We need to expand Title X. Part of addressing, we will lower abortion rates when we increase access to contraception and healthcare. So I think that's a really important thing the federal government can do. I'm almost out of time, so I want to mention one other thing that I think is absolutely critical. So recently, in mid-December, the FDA lifted a restriction on the abortion pill. They lifted a requirement that abortion pill had to be distributed in person. And while they didn't entirely lift all the restrictions on the abortion pill, which they should have because it's safer than Tylenol, it's safer than shellfish, but it is actually, I looked it up, but I see the docs laughing, but it's only restricted because of politics. They didn't lift it all, but they did lift the in-person requirement. So telemedicine abortion is proliferating across the country in the states that allow it. Unfortunately, your state is not one of the states that allows it. However, there is some talk about how if a state has a law that's contrary to FDA rulings, that the federal FDA ruling preempts the state law. So I think that we're going to see a lawsuit in the not so distant future challenging laws like the law in North Carolina about whether you can have telemedicine abortion. And let me tell you about the strength of telemedicine abortion. People don't have to cross the protesters to get the health care. They can do it online. And it's the exact same procedure because you take it home and take it anyway at home, but and the abortion happens at home, but you just don't have to travel long distances from rural areas or cross, angry picketers. And it tremendously increases access. In places like Massachusetts, where I am, there's now multiple telemedicine abortion providers, including just our normal Planned Parenthood, but a lot of others. And it's cheaper and cheaper. In Massachusetts, you can get telemedicine abortion for $149. Much cheaper. Our average cost, if you go to a clinic, it's like $600. So it's much more affordable. So, that would really increase abortion access and is hugely important. And I think that the federal government has a role in potentially asserting the FDA preemption over state laws. And the FDA also needs to remove the rest of the REMS restrictions, but that's another conversation we can have another day. So I think I've used up all my time, but I'm open to questions.
Yes, thank you so much. Yes, I'm going to turn this over to Virginia Carson, who's a member of Chapel Hill Now, and who has personally invested in promoting diversity and student activism from her time working at UNC's Campus Y until just recently. We have two people that know Virginia in the audience from those days. And we have a new young woman working with Chapel Hill Now, and we're excited about that. So Virginia, I'm going to stop talking, all right? So we can get to the questions.
Thank you. Yeah, we've had some very good discussion in the chat. And I want to go back and get a couple of issues cleared up with our local docs who have been really caring and so thoughtful about all of this. there were several questions in the chat about these, just the steps in getting an abortion in North Carolina right now, particularly the statements that have to be read to someone, whether we require 2 visits or 1 visit. What is actually the mechanics of getting an abortion in North Carolina right now?
Erica, you want me to take that?
Sure, I can start, and then Rathi, if you want to fill in. So I think one thing to recognize is that people don't typically even know they're pregnant until 3-4 weeks in. And part of that is because we date pregnancies a little bit strangely in medicine. And so you're 2 weeks pregnant the day you get pregnant. Little weird, but it's based on counting and menses and whatnot. And so when you hear about 6-week bans, many times people don't even realize they're pregnant at that time. And so once somebody becomes aware of their pregnancy and makes the decision that they do not want to continue the pregnancy, then they need to figure out where to go. And so in North Carolina, that can be complicated. If you see these billboards that say pregnant, scared, come here, those are typically crisis pregnancy centers that are trying to masquerade as clinics. So that may delay care, or they may contact their regular family doc who says, oh, I don't do that. And so there's that barrier of
And
trying
who may
to
try
find,
to talk them out of it, by the way.
right, exactly. So then once they find their way to a medical provider that does abortion care, they will need to get an appointment, which sometimes there can be a backlog of that. They need to figure out financially how they can pay for it, which can also delay care as they're scrambling to come up with hundreds of dollars. And then this is where it gets into the legalities. So in North Carolina, a physician, physician's assistant, or a nurse, those are the only 3 categories of people, have to have a conversation with the pregnant person at least 72 hours prior to getting an abortion. And they have to say certain things, some of which are not even, most of it's not helpful at all, and some of it's not even accurate. But they have to talk about, you know, the father of the unborn child, as it's written in the statute. It could possibly be on the hook for child support. So the nurse on the phone gets to say that to somebody who is a rape victim and potentially put her through the PTSD of having to think about that horrible situation of bringing the rapist to court for child support. So it's cruel, and it's not even applicable to a lot of people, but that script has to be read. It can be read over the phone. So in the chat, people were talking about, do you have to have 2 clinic visits? Some other states, you have to have 2 clinic visits, ask for days off of work twice, get childcare twice. Mercifully in North Carolina, right now, it can be done over the phone. And then at least 72 hours have to pass before you can actually have your procedure. The ultrasound that somebody mentioned before also thankfully was not actually enacted in North Carolina. It was enjoined by the courts. And so the forced ultrasound is not a reality right now, but that was also part of a bill that was passed in 2015 that would have forced women to watch the ultrasound being done, even if she didn't really want to. She could avert her eyes, it said. And the provider would have to narrate the ultrasound. So that is not in effect right now in North Carolina, but it can be reality in other places. So that's, did I miss anything, Rathika?
I think those are the main things. There's a few little things like one of the reasons that it's hard to do telemedicine is like we still have to do some lab work. We do a hemoglobin, a point of care hemoglobin, and RH testing. I think which is the RH blood type. If it's negative, they get an injection of RhoGAM to prevent future pregnancies from having a reaction. I believe the RH part is actually part of some of the state laws. Someone would have to confirm that. However, actually what we have found and what National Abortion Federation I just saw doing a presentation on, is that that's actually unnecessary, the RhoGAM, that is likely unnecessary in first trimester. So there are a lot of little things that are there. I think the biggest thing though is that the traveling childcare. When I think about some of my patients and the experiences they've had, again, like I had a really lovely patient recently with a young child who had come in for a pregnancy confirmation to our family practice, and then she came in just to confirm her dating. She actually already had her Planned Parenthood appointment, but she was going to another part of the state because it was going to be so long before she could get in our part of the state. I was happy it was me that she was seeing because she had so many questions, like which would be better. She didn't have support. She has a small child. And so we could talk about the procedure might be a better option for you because it'll be one and done. But so many doctors and providers don't really understand. They don't understand both the complexity of getting care access and all the hurdles patients have to jump through, and also just how to explain what the difference between a medication abortion and a procedural abortion is. The second thing I really am frustrated about is that, you know, in New York, when I've had friends get abortions, like IV sedation is just like part of it. Their insurance covers it. The worst part of my job is causing pain for my patients. Like it makes me physically ill that my patients are sometimes screaming in pain. And I have to finish the procedure. And that's because it's very difficult for us to have, I think, very few of the outpatient clinics have IV sedation that would make a patient comfortable. And I honestly think that that is because it's so expensive. You have to have another nurse, you have to have extra training, it costs more. And so, you know, there are things that aren't necessarily like legal limits, but that these restrictions have caused that make this a worse experience than it should be.
Thank you, doctors. That is really helpful. I want to bring Dr. Baker on our screen as well. I think a area in which we're going to see a lot of conversation is telemedicine. And I have a couple of questions about that for all of you. And as I understand it, in North Carolina, you are not allowed to prescribe abortion pills, for example, with a telemedicine visit, but doctors in other states are. What's to prevent someone in North Carolina from dialing up a clinic in Massachusetts and having an appointment and getting the help that she needs? Is that a realistic scenario?
So doctors are licensed to practice in particular states. So a doctor in Massachusetts might not be licensed in North Carolina. And so if they knew the patient was calling from North Carolina, they could not treat them and they could not mail pills down to North Carolina. That said, what's happening, especially in Texas right now, is people are using mail forwarding. So they're getting a mailbox in, let's say, Massachusetts, you know, mail forwarding, and then they're calling the provider, doing the appointment. They may have to say that they're physically in Massachusetts when it happened. They may just say that even if they're not. And then they give the doctor the Massachusetts address. The medication goes to the mail forwarding service, like iPostal, there's a bunch of them now, and then it gets forwarded to Texas. I know this is happening because right now I've done a series of interviews with telemedicine abortion providers across the country, and I can pop the link in. I've done about 6 of these interviews, and it's been very fascinating. They're sort of in-depth dives into how are you providing telemedicine abortion? Who are your patients? Why are they coming to you? What's happening? And it's been clear to me that they don't know this is happening, but they suspect it's happening. And I know it's happening. And groups like Plan C are actually promoting it on their website. They have a page on mail forwarding and how to get pills. The other alternative is people are just going over the border and ordering it over the border or having it mailed to a friend in a state where it's legal. So this is definitely happening all over. And there's really no way to prevent it. The main risk is for the doctors. If they know that they're treating somebody who's not in their state, that could endanger their licenses. But often the doctors don't know this is happening. Only the patients know. And the
It
patients,
seems to me inevitable that the boundaries will be pushed for telemedicine because the technology is there, the interest is there, and there is no way really to stop it. But it brings up what I think is a critical piece, a question to consider, and one that we are working on, and that is, how do we get reliable information out to people as to what is safe, what is safe and medically acceptable in this telemedicine world. It seems to me inevitable there will be scams also, and there will be less reputable people. Sorry, go ahead.
so I just put a link in the box. There's an organization named Plan C Pills, which vets telemedicine abortion sites and also websites selling abortion pills. So they are very reliable. They have a drop-down menu by state, so you can just select your state and see exactly how to get pills. Also, there's an organization called Aid Access. It's run by Rebecca Gompert. She's based in the Netherlands. She's a physician, and she's treating people in all the states that don't allow telemedicine. She's doing it from Europe. And then but the problem is she mails the pills from Europe, which means it takes about 3 weeks. Yes, the doctor in the movie Vessel, exactly. Yeah. Women on Waves. And she's a physician. She's fully qualified. There's complete follow-up care. She charges, it's a sliding scale up to $150. So you can get it free. If you call and say, I have no money, you can get it for free.
And
Wow.
actually, I think, many countries, people have already been doing this, and it was something that came up that women have been, like misoprostol in many countries is just available. And, misoprostol by itself can be very effective without the mifepristone, but in many countries, it's kind of by word of mouth. There is the concern that you're getting not the real pill. I had a family member in Sri Lanka who they were concerned they might be pregnant, and I helped them access Aid Access for them in case they needed it, because so it's definitely, I feel like we say telemedicine, but I think the other part of this is self-managed abortion, and I think that is what we're going to be seeing more of. It's really quite safe, and
do you see this as a different avenue for women in rural areas, rather than driving hundreds of miles or dealing with all of the childcare and family issues?
I think they are already doing this. I think this is already happening. I think self-managed abortion is already happening. And I know there are some collectives of kind of lay abortion providers who are even providing section. I don't know personally, but that is, I think if you're in the right community, you would know about it. So I think that it's, when it's a little bit under the radar, we're just not as aware.
Right.
I would totally agree with all of that.
You in the chat, Dr. Nimalendran, you said you were seeing some patients from nearby states. So people are already driving to you from Tennessee and Georgia and South Carolina.
Yeah. I mean, I'm kind of like Dr. Pettigrew, when I was at Fayetteville, we saw tons of people from South Carolina because they were fewer clinics and because they had less access. So instead of needing to wait for a month, they could get in they could get in earlier. And it does make a difference. Having an abortion at 6 weeks is much different than even a medication abortion at 10 weeks. A suction procedure at 7 weeks is a breeze compared to a suction procedure at 14 weeks when you're awake. Yeah. And then I think the other thing to say is with fetal anomalies, like I'm currently 18 weeks pregnant. I have my anatomy scan coming up. But I know that if I needed to have an abortion at 20 weeks, I would have the funding, I would have the wherewithal and the knowledge of how to do that. And most people don't, and often then have to continue a terminal pregnancy that often leads to many pregnancy complications and infant death.
There's a question in the chat that I think is worth raising. How to disseminate the aid access into rural areas in a timely manner? For any of you.
I think social media is key. I know a lot of these telemedicine abortion providers I've been interviewing are using Instagram. They're, because, or TikTok. I mean, the things that are reaching young people who are disproportionately people needing abortion access. Even low-income young people have phones and go on social media, and so finding ways to reach folks. Even something like what happened on, there's just different, like Shout Your Abortion and other kinds of groups are working on how to reach people, that might not otherwise hear about this. That I think is key to increasing awareness, but a lot of people don't know about it yet. Right before Texas banned abortion, Plan C took a van with big lighted billboards on either side and drove around West Texas, including the universities, handing out candies and information about abortion pills, trying to raise awareness before the law went into effect. This was in late August. I wrote a piece about it for Ms. And, just all kinds of creative ways that people are trying to raise awareness about abortion pills.
There's one other segment of the population that I think is important to highlight that we saw a lot in Fayetteville, and people with TRICARE and active military, also their abortions are not covered. So I saw many women who had to pay out of pocket for their abortion and go right back to active duty. Oftentimes it was because they needed to deploy or whatever. And I think that is also a travesty and something that we're often not even thinking about.
There's a comment in the chat that many rural areas are still lacking the internet. And that's certainly an issue in North Carolina, but almost everybody has cell access and internet connections. Yes, at the library, at schools, at somehow they can, I believe that they can find access. And I'm more concerned that we're getting out reliable information because almost everybody is able to access TikTok and Instagram and the like.
And I think though that's where there is a paradigm shift here. And I think this is a lot different than decades before because, Dr. Nimalendran just mentioned self-managed abortion. That's not, for many medical providers, I can't speak for all because there are differences of opinion, but in general, we're not saying that's a bad thing. It can be very safe. It can be empowering, and maybe we've over medicalized this. And so, the idea of, that's why there's a lot of controversy now about the idea of using the coat hangers as a symbol, because it's no longer necessarily about after Roe falls, we're going to have back alley abortions and things like that may happen, but it's more about, okay, this is a new era. How can we shift this to patients? How can we empower them to make decisions safely? And really, medication abortion is super safe, and there are protocols to do it without ever getting your blood drawn, without ever having to get an ultrasound, and that's still very safe.
I also think that this goes back to medical school teaching, and I will even say even high school education. When we're teaching abstinence only education and my patient who's literally had 2 babies doesn't know what the difference between her vagina and her urethra, that's not okay. We need comprehensive reproductive, like know your body. Like my sister's 10-year-old in Wisconsin is getting their health care course. They're learning about like self-care and like meditation and their body parts. Like we need that everywhere, because that I think is one of the huge huge deficits we're seeing. And then also abortion care and abortion management is not necessarily a part of most doctors' training. Like me and Erica seeked it out. We had to go out of our way. I have to moonlight in addition to my full-time job to do this work because there's so little support for it. So when a patient comes in and they see their regular family doctor, they literally have no idea what to tell them because they have never been trained in it. So how do you get good information when your teachers, when your education system, and when your healthcare system doesn't know what the right information is?
Well, and I'll just mention too, in terms of training, there's a different problem that doesn't get talked about a lot, but I trained in Oregon, in Portland, and in part I went out there because it was the only state without any restrictions. I wanted to not get sidetracked by politics while I was there and just focus on medicine. But ironically, because, and this is a good problem to have, but because everybody in my residency class really wanted to learn, we had too many learners. And because Oregon's abortion rates were going down, and there were some other reasons too, we didn't have enough learning to go around. And so ironically, I had to leave Portland to come back to North Carolina for 6 weeks to train at a clinic here in order to be able to provide care. And so there's just a lot of issues in abortion training right now.
That I am gonna let you go in just a minute and a half because we put a time limit on this. I cannot thank you enough for really kind and thoughtful comments. Any last words you want to give to our audience here?
I'll just say thank you for listening. Thank you for spending your Thursday evening on this. This is a huge issue, and but I just hope that at least from our perspective, from the provider perspective, we just really enjoy providing this care. And I know that Rathika and I both feel very strongly that this is just part of primary care. And so thinking about ways how it can be folded back into primary care is something that we talk a lot about.
Definitely, I 100% agree. I think at the same time, we sometimes get the public rally when something big is happening, but this needs to be on people's minds. People need to also not just tell me quietly, oh, I'm proud of what you do. I need you to be saying that loudly. I need you to be saying that to everybody. And again, I think this is part of abortion is part of healthcare. I work in substance use. It needs to be part of options for those people. It's part of having healthy children and healthy families. And we are doing a disservice to our country by not making it more easily accessible.
Thank you.
I'd like to speak for the needs of disabled women in this state. The fact of telemedicine, I think, is a very important option for disabled women who either may not have transportation to get to a facility. Last time I was at the Raleigh Planned Parenthood on Morgan Street, they weren't even wheelchair accessible, much less having accessible tables. And how that can be a factor in this state at this time after the ADA is passed, I do not know. But I constantly pass out my business card to tell people that I will provide wheelchair accessible transportation for women who need to get an abortion. But if we've got telemedicine, we need to be thinking about these things as disabled women, because traditionally we're not thought of as sexual beings, much less getting pregnant and not having a social worker who will take your baby away from you because they don't know how you live your life as a disabled woman, much less taking care of a baby. And those resources need to be there for women, disabled women.
Thank
and
you.
It's
Gailya,
not.
were you going to close us out?
Yeah, well, Gerry's going to close us out, but I do want to say we're so thankful for our doctors, and also for Professor Baker for informing so many people with your articles and your willingness to take time to do events like this. We appreciate you guys so much. Thank you.
Okay, I just will echo a little bit of what has already been said. Thank you to to our audience for your attention, for your involvement. Appreciate that. Couldn't do that. I mean, it's nothing without your audience, and to our speakers for what they have done. It's clear that all of us and everyone in this country, and we've learned as an international issue, every woman in the world who cares about women's rights, about safety, about health, have a lot of work to do. And that work really has to start right away. Indeed, this event really is the beginning of the work. Tara Romano is out there in the audience, I know, and I'm so grateful to her for a recent article that she wrote, which leaves you with many options for help to continue. We don't want to go without there being something that we can all do. And Tara has a lot of options in her article, which is, I think, one of the ones that's recommended in the brochure. But now is the time, she says, now is the time not to be silent. All right, we have to share our stories, which we have done. We have to speak up when we see that there are unfair and untrue things being said. All right, and we have to let our elected officials know. And this has come up a couple of times, we have to get out the vote. We have to vote ourselves. We have to encourage others to vote. We have to know who to vote for. We have to ask those questions. Where do you stand on these issues? And we have to support those people who stand with us. We can't go through this again and again. It's just wrong. All right, support those candidates. And as someone else said, I'll echo it again, the whole ballot needs to be voted on. Every person, every office is important, every election is important. So let's make a pledge to do that. And just finally, we've heard a lot of talk all around in the news media about the end of Roe, but our future is not prescribed. What we do can affect what happens in the future. And let's never forget that. Let's continue the promise of Roe. Thank you all. I think, oh, I went over, sorry. Thank you, everyone. Good night.
Thank you, Gerrie. Thanks, everybody.
You're welcome. You're welcome.
Thank you.
All right, so good to get to talk to you both.
Yeah.
Great.
Yeah.
Thank you.
Thank
And
you so much.
Good luck with your work. All right, Gailya, good night.
Good night.
Night, lady.
Great job. Night, everyone.
So Vicky, you staying on? Hi, Nancy. Hi, Joy. So glad you guys could join us.
Hey, Gailya.
Yep, you're staying on.
It was wonderful.
Hi, Paul. Hi, Representative Insco. We did recognize you before you got on. Hi, Olinda.
Hi, excited doggy in the background.
Mason, come here. Come here.
Well, it was fabulous having doctors too. Really fabulous. I still have more questions, but they'll have to hold.
Oh.
So, all right. Thanks so much, Vicky, for handling all the background Zoom stuff.
Sure.
And Joy, I'm glad you asked your question out loud. Like we saw it in the chat, but it had to come out loud. That was wonderful.
Thanks.
And thanks everybody for joining us.
Good night, all. I've got to wrangle the dogs.
Good night.
Good night.
Good night.
Night.
So, yeah, so that was great. That was
If you're
really
wanting to
informative.
chat, I'll just go ahead and close it. No, go ahead and remove you guys if you're maybe walked away from your computer or something. Thanks for being with us.
You can put them in the waiting room, actually.
Yeah.
Doop, doop.
There we go.
Okay. Yay. All right, so we did it.
I love Spotlight.
Yeah.
It's
Yeah,
just one of the people I was having trouble finding. I was like, where is she? Where is she?
So I never saw Audrey, which is a shame. I should have just said what she said.
I don't
or,
think
you
she
know,
was. I don't think
paraphrase.
she made it in.
No, I don't think so either. She was having a whole ERA day because this is the 2-year.
Oh, I got to stop the recording. Hold on.
Oh yeah. Oh yeah.